Hey, so we like to start our days with this clinician panel just to hear from local experts on what's going on. So why don't we start with some introductions of everyone, share who you are, what institution you work at, and what diseases you specialize in.
Well, Adil, Javed from Chicago. Well, I'm probably the oldest here in the panel. And what diseases I do look younger, though.
You look very young.
But what diseases? So multiple sclerosis, way back in the day, NMO, MOGAD, autoimmune encephalopathy, sarcoid, and just about what patient wants me to listen and talk to them about what ails them, and I can, do my best to treat them. So I think as you get older, you become more of a generalist. When you start your specialist, then you figure that you just take all the newcomers. And as you age, you just learn more and more, and then you become sort of you can treat just about multiple things. So since I'm the oldest here, I guess I can, treat many things. Depends on, as you get older, like Dr. Arneson, my mentor, God bless him, and rest his soul, he basically saw just about everything. And he was an expert in everything. So it comes with age, but I'm not that old yet. so I'll pass it on to Dr. Cipriani here.
Hi, I'm Veronica Cipriani. I was trained by this gentleman right here, and I will tell you this is how he always is. So. I also work at the University of Chicago. I stayed on after my fellowship. I've been an attending now since 2018. I am the director of the MS clinic at the University of Chicago, so I see a lot of multiple sclerosis, but I also see all neuroinflammatory disorders, and I have a special interest in autoimmune encephalitis, so I'll be on the panel later talking about that. So thank you so much for inviting me to be here. I'm really excited.
All right. Hi, everyone. Is this working? Yeah. Okay. I'm Shailee Shah. I am probably the newest person to Chicago. I am a neuroimmunologist at Northwestern, but I think it's kind of exciting. I split my time between downtown and also the west suburbs, and I specialize in the treatment of both multiple sclerosis and kind of all other autoimmune neurologic diseases. I'd say probably strive to become an expert in everything, like Dr. Javed, but still getting there. But certainly focus on autoimmune encephalopathies, antibody-mediated diseases, NMO, MOGAD, so forth.
So I introduced myself before, but few things that I didn't say. So I trained here at Loyola and with Amy Pirin-Ross, which is here in the audience. And Amy was a wonderful mentor and very influential in my decision to become an MS expert and neuroimmunologist. I'm actually not that much younger than Dr. Javed, but I try to avoid talking about age here. But the other thing that I want to say is that my wife and I, we funded a nonprofit back in 2018 about brain health and about patient education. And I think actually understanding the importance of self-advocacy through knowledge. I agree with Sumaira that education is power. And I always challenge all of us thinking that medical education and patient education should be part of what we do as healthcare providers. So we are proud to say that we co-sponsor a NMOSD and MOGAD masterclass. That's a 2-week program along with the Sumaira Foundation to help patients understand things related to brain health, nutrition, exercise, the importance of symptom management, and everything that we discuss in those classes are evidence-based information specifically targeted to our patients, so for them to not only understand why it's important to follow a healthy lifestyle, but most importantly, how are we going to do that in our day-to-day life? So if you want to participate, the flyers are somewhere in the hall, and I encourage you to sign up. It's completely free, and it's a 2-week program.
Okay, is this on?
Yeah. Yes.
These microphones are not good, by the way. Okay, so yeah, I met everybody a few minutes ago. So yeah, I'm William Conte. I'm a neuroimmunologist just over the border in Miravalle, Indiana, at Methodist. I mean, Methodist is I would argue, actually the largest in the top MS center in the entire state of Indiana at this point. And, MS patients are what we see most of the time, but over the last year, I'm the specialist in all the weird stuff in Indiana. I don't know, all of a sudden, like, all the weird stuff's coming to me, which is great. Just to highlight some things that, it goes full circle here, right? So, I hail from the University of Chicago for my neuroimmunology fellowship with my mentors right over there, who I don't know what this philosophical age reference was just now, but, he trained me very closely. And then Dr. Cipriani was my co-fellow for 1 year, and then my attending for 1 year. So it all goes full circle here. And then just like Dr. Miravalle, I did my residency at Loyola with Amy Perrin-Ross over there as well. And so everything goes full circle. I mean, I guess Dr. Shah, we're not really involved in this circle quite yet, but I'm hopeful it will. It always comes full circle. And just to highlight what Dr. Javed said, I mean, neuroimmunology really, I think sometimes we, are all of the subspecialists, we kind of like sometimes, I don't know how to say this in a political way, like kind of throw shade a little bit at general neurologists sometimes about, sort of hodgepodge care. But honestly, like neuroimmunology really truly is like the ultimate general neurology specialty of neurology. I mean, because these diseases can cause anything to happen, really anything, which is both a blessing and a curse, right? I mean, because patients with weird neuro symptoms present to us. It's not always neuroinflammatory, but often it is. And really, the medications these days really are so effective at preventing further damage, but yet patients still are left with prior damage. And really, I think we're all pretty skilled, really from top to bottom, head to toe, of really symptom management, complications, and really, it all goes back to general neurology in that sense. So happy to be here.
Thank you to our wonderful panelists. So I'm going to start with the first question. So this event is special for so many reasons, as I already outlined. But one of the really extra special things about today is that in addition to our usual NMOSD and MOGAD community that we always invite, we've invited some friends of NMOSD and MOGAD. So we have patients, caregivers, and clinicians representing autoimmune encephalitis here, and that's also represented by the Autoimmune Encephalitis Alliance. So thank you for being here. And then myasthenia gravis community is here, represented by the MG Holistic Society, and stiff person syndrome, represented by the Stiff Person Syndrome Research Foundation here. So that being said, we're going to be trying to cover all of these disease states today. And during the breakouts, we'll dive deeper. So we'll try to keep it a little bit general here. So, we've got a wide diversity of patients here living with these rare conditions, but one common theme is the complexities of the nervous system and how it interacts with the immune system. So can you all, or whoever, share your perspectives on the field of neuroimmunology, as we kind of touched upon, and recent developments that patients should know about, especially as we're seeing more and more of these rare neuroimmune conditions? Anyone can take.
Well, I can start if you want. So I think one of the unique aspects of NMOSD particularly is that, when we compare the trajectory of science and drug development in multiple sclerosis, it was more of we learn about the disease as we understand how these therapies work. So the process of understanding the pathology of the disease, understanding the why on MS, and understanding how these drugs worked was almost parallel and simultaneous. In NMOSD, actually was not the case. So we learned a lot about the disease itself, these antibodies targeting this, aquaporin 4, and what are the consequences of that. And then the therapies have been designed with a knowledge base that, targeting this process is going to cause some benefit in the disease itself. And we went from having absolutely no options. We were using off-label medications like rituximab, Cellcept, and Imiran, to now having 4 approved therapies that has been designed and developed with the knowledge of the disease itself. And not surprisingly, that's why we find that they're so effective, because we truly understand the basics, or a little bit even deeper than the basics, of the pathology and NMOSD, and then we apply that knowledge to develop therapies.
I think neuroimmunology is a field that has a lot to be explored. we're understanding diseases a lot better now, and there are new antibodies that are constantly being discovered, new syndromes that we're learning about. I mean, I remember when I was a resident, I feel like MOGAD wasn't even on the differential a lot of the time where it should have been, and I don't consider myself as old as some of the other people in this panel, so I think another one of my personal interests is the neurologic complications of systemic rheumatologic diseases. And, one of my mentors here published a landmark paper in 2009 about the connection between Sjogren's and neuromyelitis optica spectrum disease. And I think I see a lot of patients with RA, with Sjogren's, with lupus that have neurologic complications. So not only in just the neurologic space, but working a lot with teams from other types of specialties, like rheumatologists especially, to come up with a diagnosis and a treatment plan. It really takes a village with some of these syndromes.
Yeah, and I'd just like to add, I actually think, everybody thinks the brain's the most mysterious system of the body, but I actually would argue it's the immune system that actually is the most mysterious, like to this point, science-wise. And the fact that we're talking about both brain and immune system together, that's just, very mysterious, like what is actually going on, how it develops, how we manage it these days. And I just want to add, this is especially more so with the MS that Dr. Miravalle was talking about versus NMO, but the science builds on each other, right? That's very common. Once we sort of find the first sort of hint at something, then all of a sudden everybody goes after that, and then we learn more and more and more. So science builds, which is great. Technology advances, and it's really good times most of the time. I think also the problem with these rare diseases, just because they're so rare, it's hard to do studies on them, recruiting patients. They take longer to do, right? In the MS world, there's so many patients with MS, you can, recruit a big study very quickly, usually, whereas, these are small numbers. It's just hard to get patients enrolled and do these studies. So it's just, it's all good times. It's really fun stuff, actually.
Is there anyone in the audience who has not yet been diagnosed or kind of like in between diagnoses? Okay. Oh, so so this is really to help you guys. So I don't know if there's a simple way to do it because we have so many disease states we're representing, but maybe briefly, what does a diagnostic workup look like for NMOSD, MOGAD, AE, SPS, and separately MG, if you guys can tackle it?
I think it starts with the clinical presentation that brings the patient to the medical sort of attention. So each of the different diseases we have, NMOSD, MOGAD, autoimmune encephalopathy, name any other autoimmune diseases in patients who may have, say lupus or RA or Sjogren's, I think it's the initial manifestation that brings to attention. And now there are other autoimmune diseases like multiple sclerosis. The patient's already behind the eighth ball because the disease is brewing for a while, and we've all seen patients who come in with optic neuritis and have 20 or 30 or even more brain lesions, even including the spine. So it depends. So each autoimmune disease, to go back, is very unique, and what manifests the disease presentation in different sort of background. For example, why is NMOSD such high prevalence in blacks versus Caucasians and so forth? So it's the genetic, the epigenetic, the environment, the milieu that they're in. Everything matters, but really it's the initial presentation. So if you have an optic neuritis, a patient comes to Dr. Conte with optic neuritis, there's a large differential, right? There's a large differential of patients. Could it be NMO? Could it be MOGAD? Could it be just idiopathic optic neuritis? Could it be post-viral? Could it be drug-related? Could be infection. So there's a large set of differential, and you start to nitpick everything. You start with laboratory, MRIs, spinal fluid analysis, and each time you get a test, you weigh it. Is it NMO, MOGAD? So it's the initial presentation and a comprehensive workup that directs you in a direction.
Yeah, just to add, it's a lot of pattern recognition, and also lots of little pieces to the puzzle ultimately. Unfortunately, we just don't have technology in any of medicine of just this just tests for everything, right? It just doesn't exist at all in any kind of field of medicine. So a lot of it's pieces of the puzzles and pattern recognition.
Yeah, one of my mentors in residency said that 80% of your diagnosis is going to come from the clinical history. And as neurologists, as a group, we really like to solve puzzles and solve mysteries and really deep dive into the story. So that part is really, really important. I think that, we get other biomarkers. We get blood tests, MRIs, spinal taps sometimes. And sometimes, the reason why the clinical history is so important is because sometimes we'll get a low positive test, like a low positive ANA or a low positive GAD antibody or a low positive other test that, if it doesn't fit with the clinical history, then that might not actually be the answer. And I think that can sometimes be the hardest part and where a lot of diagnostic uncertainty comes into play. So, really make sure that, your doctor that you're seeing is delving into the clinical history and asking you a lot of questions and giving you time to tell your story.
Is anyone here a seronegative patient? Just me? No. Okay. All right. Can we talk about seronegative NMO, MG? Like, how often should patients be getting retested for these antibodies? Like, what does the future for seronegative patients look like?
Yeah, it just comes down to the history again, right? So as much as we like to see innovation and science, progress in terms of applying more precision medicine and biomarkers. But at the end of the day, I agree with what says before. One of my mentors used to tell me the most powerful tool that we have as clinicians is a chair next to your patient. Just sit down and listen. I think from your standpoint, what you can do to advance your care is come prepared with a list of, very clear timeline of events. And, dates are very important because these disorders are chronic. They're relapsing. So it's important to understand when did these symptoms occur. And we apply that process when we are dealing with a seronegative NMOSD patient because we don't have the benefit of the biomarker to help us increase the accuracy and the sensitivity of the test. Whenever there is a strong clinical suspicion, whether the patients have a classic optic neuritis or a classic longitudinal extensive transverse myelitis, a lesion that is actually long, that actually follows the pattern, we were talking about pattern recognition before, of the process that we know is targeting certain parts of the central nervous system. So we look at the morphology, the shape, the size of these lesions, the location is important. But also we dive into more rare presentations, like the presence of hiccups or symptoms that actually localize to the lower part of the brainstem. We'll look at other symptoms like sleep interruptions or even cerebral symptoms. So we pay attention to pretty much the clinical presentation. And then what we do is we try to piece all those parts together, and not infrequently we have to repeat the test multiple times. We pay attention to the type of test that we send, and I personally, my record is 6 times that I sent the AQP4 testing before it came back positive. So we often have to do it multiple times when we have that strong clinical suspicion to truly define the syndrome, but also a positive test can open possibilities for patients to have access to medications that are mostly approved for seropositive NMOSD patients.
And I think to kind of piggyback onto that, right, I really very much echo that ultimately for seronegative patients, it's really going to come down to the clinical history, those timelines. We obviously don't have the benefit of having these tests up front. And ultimately, I think even if patients don't end up having a positive test, this is where I think all of us as neuroimmunologists come in is kind of understanding that that this is something that could potentially continue on, that this is something that has affected certain areas that are affected in diseases that are antibody positive and likely are treated by similar or the same treatments. And so recognizing early on, because we know there are often delays in diagnosis in these patients, that there may be a need for additional immunosuppressive treatment and long-term treatment so we can prevent the sort of disability that can happen in the long term. So I think, ultimately with seronegative disease, my hope is that we have other biomarkers as well that we can eventually identify. That's where all the research everyone has been talking about comes in. Just because it may also be that these are a slightly different subset of patients with different disease pathology that we need to learn how to better address.
Thank you. So across all of the diseases that are here today and that are represented, there are some unique symptoms, but also some shared symptoms that overlap. So they could be visual symptoms, movement challenges, neurogenic bladders, bowel, sexual incontinence, chronic pain, weakness, muscle spasms, muscle stiffness, memory or cognition effects, speech deficits, side effects of powerful therapies, et cetera, et cetera. So what, in your opinion, and you can speak on each disease if that makes you more comfortable, is the ideal multidisciplinary team? What specialist does that include?
Well, if you talk about, say, NMOSD for a change, and like you said, there are shared areas of involvement between several diseases such as MOGAD and NMO and other autoimmune diseases. Say, for example, if a patient presented with NMOSD has transverse myelitis. So the challenge is that, in that patient, the most frustrating things are pain and bladder and sexual, dysfunctions, bladder being the most important one, because if they can't empty their bladder, that can initiate, some pathogenic processes that can lead to trouble. So for that patient, it's a neurologist, and also it's a really urologist. So we work hand in hand. Actually, we have a relationship with our urologists. I like to see them. They can do urodynamic studies. They can do multiple, medications to treat specifically what bladder dysfunction is, like urgency when a patient has to go a lot, retention when patient doesn't go a lot, combination of both, or dystergia, detrusor, sphincter dystergia, when one sphincter contracts, but the bladder, also contracts. So there are different modalities of treatment for those patients. So we work hand in hand, sometimes with pain specialists. So if thoracic cord, if the NMO involves that, that's exquisitely sensitive hyperesthesia, pain, allodynia, and bladder. So pain clinic, bladder, urologist, and as neurologists, we take care of their immunological treatments, and also pain management and other things, and we coordinate all care. If the patient has optic neuritis, the neuro-ophthalmologist becomes a more important, physician to treat. So,
how about mental health?
Yeah, actually, I think this is a really, really important component of it, and one of the aspects of the team that I think has become really, really important, at least in our clinic, is that we have not only like a case management social work team, but there are also individuals who are trained as licensed clinical social workers who have psychology backgrounds who can help with counseling, and that can be for many different things. A lot of times it's for coping with the disease in early stages, and also potentially for dealing with symptoms that arise, chronic pain, for example. It's been really kind of an amazing addition to the team that we have, people are so spread out. It's also been really nice for patients because they have access to these resources now from the comfort of their home because we can do these things virtually.
This is the perfect segue. Dr. Miravalle, can you tell us all about brain health and why, whether you have a disorder or not, brain health should be priority?
Absolutely. Thank you. Love doing that. So, and how much time do we have? So, no, brain health is important. And by the way, when we say brain health, we truly mean the entire central and peripheral nervous system. So this applies to nerve health and spinal cord health. But the term is brain health just because we try to simplify it. But, we are in a state in neuroimmunology in which now we have the tools to address the pathogenic processes that cause the disease, whether it's NMOSD or MS. We can actually influence the process of the disease with immune suppressants or immune modulators. But that's not the end of the story. So there is more to brain health than just simply affecting one part of the puzzle. Things like diet. It was mentioned before that environmental factors play a huge role, not only in increasing the risk of developing these disorders, but also when someone has a neuroinflammatory disorder, by increasing or decreasing inflammation. So what we eat is going to affect the bacteria that we have in the gut, and that bacteria called the microbiome has a profound effect on immune responses. Not surprisingly, we find that foods that are so-called pro-inflammatory, like those trans fats or those delicious fried chicken that we like to eat, but well, that's not so good for us, right?
Hot dogs we're having
Hot
tonight.
dogs, that processed meat is terrible for what we do, or things with high content of salt. And I learned my lesson that I shouldn't talk about bacon because people love bacon, but it's not good for you. But anyway, so I'm not going to go to bacon yet. But we know that on the other side of things, healthy foods, we looked at those antioxidants or the superfoods like the berries or kale or any dark leafy green type of food are beneficial for our diet. And actually, we can change the microbiome in 4 weeks. So if you truly are serious about changing your diet, you can truly affect the content of your microbiome very quickly. 4 weeks is a rather quickly change for any biological process. So that's one example. So nutrition is one. We know that exercise has equal benefits on brain health. And now we have a dose, and that dose came from multiple scientific studies, and in MS, studies in Parkinson's, studies in mild cognitive impairment, and even healthy aging. And that dose is 150 minutes per week. Not surprisingly, every study showed the same trend. So people who exercise for 2.5 hours per week for more than 6 months consistently have a brain health benefit. And we even have published guidelines in MS, but I think that could be applied to NMOSD as well and MOGAD, on what type of exercise, whether it's aerobic or strength training. So it's very important to actually understand these concepts and incorporate them into your life. And there are other pillars of brain health. I don't want to actually bore you to death, but things like weight, smoking, sleep, symptom management, pain, and mental health. So those are important pillars to understand. And again, another plug for our brain health program or masterclass. We dive deep into these concepts, and also we provide a clinical space here at Rush called the Brain Health Clinic that actually patients can meet one-on-one with a nurse practitioner, and she will do a baseline assessment of all these pillars of brain health and develop a personalized plan to benefit and change these areas perhaps that we need to change.
Perfect. Thank you. I have one last question for the panel before we open it up to the audience. But did you know that only 5% of the identified roughly 11,000 rare diseases out there have an FDA-approved therapy? So that means that 95% of thousands of conditions do not have an approved therapy. But the good news for the diseases that are represented here are that in autoimmune encephalitis, there are 3 clinical trials. In myasthenia gravis, there are 7 FDA-approved therapies, which estimates to be about 1 approved therapy every year since 2018. In MOGAD, there are 2 clinical trials going on right now. In NMOSD, we have 4 FDA-approved, highly efficacious therapies. And with the stiff person syndrome, there's a CD19-directed CAR T-cell therapy in development. So this is all really, really good news. Of course, I don't wish rare disease upon anybody, but I feel very grateful alongside everyone I hope here that at least we have treatment options available to us that are designed for our conditions. So that being said, how does that change your clinical practice now that there are options to treat patients?
I think it's a great thing. More options are better because every individual is different. I mean, they have a unique set of symptomology diseases, so having more options. Patients have reactions. Their tolerance is different. Their disease might be different, so having more options gives you more leverage to, switch therapies if the disease changes or something happens. Having said that, it's very nice that all these trials are going on in the U.S. and the Western European, but there's a world at large out there that also have the same diseases. And it's wonderful we have these therapies, but there's big questions, the access. We have access issues right now in this country, not to mention the world at large, but we are part of the world, I think. I think it's great to have access, but when we try to get approval in this country for some of these medications, there is a red tape that we meet. So I think it's great, and the trials are great, but I think there needs to be work done on access.
Absolutely, yes.
Yeah, I mean, sorry. I mean, it's like crazy, especially for like the NMO world, just like how effective the drugs are, just all of a sudden. And this is like, so I don't think any of us were up on this stage before the era of bezaceron for MS, right, which really changed the field of neuroimmunology in 1993, right? So none of us, right? Yeah, we've all had the luxury of disease-modifying therapies for MS. I do think almost all of us were, I think all of us were at least in the medical field before the era of FDA-approved NMOSD therapies. However, at least with that, we were using some pretty effective off-label drugs. I mean, I had never heard of MOGAD in residency before. I mean, and that's not that long ago. So like, all these new diseases are coming out, and it's almost hard to keep up with the science behind it. So it's just like really cool times because, some of these medicines are so targeted and they're almost curative at a point. But yeah, access, I mean, even in this country with insurance companies, I mean, it's a total shit show these days. Just to put it very lightly, actually, if you guys know me, you know my opinions on that. So if we're having issues in this country, what's the deal with, some of the, South American countries, rural Africa, Eastern Europe, what's going on there for these patients? Are they even getting diagnosed? First of all, right? So, I mean, this is a greater issue.
And I will say, coming from like the autoimmune encephalitis perspective, we have very clear outcomes research on second-line therapies, including B-cell depleting therapies, being very helpful to prevent further relapses or worsening of the disease. And I fight with insurance companies every single time. It is, it's something I've gone to like the Illinois Board of Insurance, and they will still deny it, saying that it's experimental, even though I could give them paper after paper after paper on how effective it is, which is why I'm really glad that foundations like yours are here to advocate for this and going to the Hill. I think just the more we just have to fight and fight and fight to get access for these rare diseases, because it is life-changing to be able to treat them, and so frustrating when you get told no all the time.
It reminds me when, none of these therapies were available back in 2008, 2006. You guys were kids back then. But we had a really hard time getting rituximab approved back in 2006, 2008. I mean, I would admit patients to the hospital and just do it under the blanket of the hospital.
You used to get in trouble for that, too.
I used to get so many slaps on my hand.
Why are you spending all this money in the hospital?
It's like, why did you do this? And I'm like, I had no better choice. And I would get slapped on my wrist. Don't do it again. I would do it again.
That's a good doctor.
I mean, and to add to that, we still do that. I mean, if that's what we need to do, we'll do it. And I agree that access even here is, I mean, you're in northern Indiana, we're out in the suburbs, right? It can be very challenging to get patients the care they need. And so I think as that kind of expands and grows, and as we have these FDA-approved treatments, I mean, I can't even imagine a world in which we didn't have them. And so, it's just, it is kind of great progress, but obviously a lot to do still.
Yeah, I mean, even with the FDA approval of the NMO drugs, we still fight getting any of them approved, right? They want us to step through off-label medicines. Like, huh? Right? I mean, in the MS world, we're still fighting with getting high efficacy therapy approved because the insurance companies prefer lower efficacy, lower efficacious medicines. Like, huh? Right? I mean, it's continued. I mean, even in this country, even Europe. I mean, there's all these internal guidelines with the government-run, I don't know what to call them, like government payers, I guess, right, of how you get to a certain medicine, right, even in Western Europe, and that's just not to say about the other countries. So, I mean, it's terrible sometimes.
I agree, and I just want to highlight the importance of your voice, because your voice truly matters in these cases. Whenever we get no as an answer from insurance companies, we usually go through the same process trying to appeal or write letters. But at the end of the day, your voice is what should be heard. And so whether it's through advocacy, whether it's through foundations like the Sumara Foundation, or actually days like today, like showing up like you all did today that matters, and that actually creates a sense of community. And we are working with Marian Jones and all the wonderful community here in Chicago to create a patient support group, but it's not going to be a support group like traditionally we think of. It's going to be just a network of individuals sharing the same story or similar stories. And I think one of the exciting part of that is the advocacy, right? They create this shared front that, along with your healthcare team, actually we can fight for you, and I hope that we're going to have a stronger voice.
Perfect. Oh, yes. Speaking of your voices, does anyone have a question for any of the panelists? We have some mic runners around. Raise. Oh.
I probably don't need a microphone.
Okay.
Good afternoon. Thank you. I just have a comment and a question. My question would be for Dr. Miravalle first. So I was getting something to drink when you were giving the edits, if you will, on the diet and brain health. If you can please repeat those for me, except the bacon part.
Yeah, absolutely.
I'm just kidding.
Happy to talk about that. But yeah, diet is fundamental in terms of brain health. And what I was explaining is that the microbiome, which is the bacteria that lies on the gut, has a direct effect on immune responses, whether it's stimulating immune responses, challenging immune responses, or actually changing the way your immune system is going to react to other antigens. And the gut is determined by what you eat. So if you follow, for example, a regular diet that is full of trans fats and greasy foods and fried chicken, and if you eat that every day, and one day you decide to eat a salad, what's going to happen to you? What type of symptoms are you going to have? You're going to be bloated, perhaps gas and diarrhea. And why is that? Because your bacteria is telling you, I don't know what to do with this. I don't know how to metabolize these foods. I'm going to eliminate them. And the same is true in the opposite way. So if you follow a very healthy diet with salads every day, and you eat blueberries and you eat fruit, and one day you have a burger, it's not going to feel good. So what that's telling you is that your gut microbiome adapted to metabolize and work with the foods that you give. So that microbiome is going to also influence your immune responses. So there is a direct link between the two, to the point that now we are learning from the MS field that when you look at, for example, the composition of the microbiome between identical twins, where one has MS and the other one doesn't have MS, they have a different composition of the microbiome. So there is more to the story, but while we wait for the results, I think all we can do is eat healthy. And among those things, I hate to tell you, but bacon is not the healthiest choice that you can make.
Yeah, we can do without bacon. Then the second part is patient education. And Dr. Cipriani, and I think for all the panel, I think the biggest challenge is, and as we are in the era of therapeutics, they've been helpful. So I'm on the technology side, store side of that, so I know how we got here. But the biggest challenge is that patient education. How do we advocate? How do we support at your local level, the state level, before you even get to the people who actually, get these people on these panels, on these commissions and things like that? We see the commercials. I know most people have no idea what these therapeutics do. And I think it's because we don't have the best educated population in the world now. But it's just very important to have something as simplistic as food, as brain health, and other things that we can pitch towards that. But I think, the idea of patient education is everything, because that's where the teamwork comes in at. So thank you.
I do think there's a big component of equity, too, that plays into this conversation, because I have patients where I practice that, I ask them about exercise and they say, well, I can't really take a walk in my neighborhood. I don't feel safe taking a walk outside my neighborhood. Or, I can't afford to go to a gym. Or, the only grocery store in my neighborhood is being shut down. And those are things that I deal with in clinic on almost a daily basis. And so trying to adapt to how can we work in a healthy lifestyle as much as possible, like within the confines of the patient's environmental situation, is also really important, and something that I grapple with and think about a lot. I don't have all the answers, though, unfortunately.
I think there's a reality we live in that eating healthy is very expensive. And I mean, so, when we see patients and everything, we talk about that. healthy eating and exercise. But when we're talking to a lot of patients who have jobs and now their job is being compromised because now they're ill and they have, children, they have other duties, they have, other things to address. So it's a hard conversation to sort of talk about that and have time to talk about that. But we do our best. But there's a real world out there that makes it very difficult. And I think there has to be something changed more politically and in the socioeconomic sort of atmosphere we live in.
Any other questions?
No?
Hi, I'm curious about treatments, therapies that are in the clinical trial phase, which is super exciting for patients. A lot of patients are very desperate for better treatments, frankly. And I'd love for any of you to speak to the process and timelines to get treatments in the clinical trial phase to FDA approval. And then what is having an FDA approved treatment, what does that mean for patients?
I can take that. I mean, so if you find a molecule, say Dr. Conte finds a molecule, it's like, this is going to help my patients, I've discovered something, and they've tested in little critters, mice or something like that. To take that molecule to a phase 3 clinical trial and get the approval, if it all works out, the clinical trials have phase 1, phase 2, phase 3. Phase 1 is just a mechanism study, and phase 2 is somehow safety and mechanism and dose finding, phase 1, phase 2, and phase 3 is actually tested on a large number of patients to look at the efficacy. And furthermore, to take from mice to humans, it's about $1 billion. If not more nowadays. So you have to have this clinical development program and $1 billion. And when the FDA looks at it, depending on the primary endpoint, say relapse rate in NMO or anything, if it's efficacious, then they get the approval. When they get the approval, so who funds these clinical trials? It's not the NIH. They don't have any money anymore, actually. So who is funding all this? And we have some partners here. They fund it. So they're the ones who submit the application. They're the ones who get the PDUFA date, and drug is approved. To get that medication to a patient is another ordeal for all of us, actually. And we've been there. So the medication gets approved, and we say, okay, when it's going to be on the shelf, and what the insurance consultant look like. How do I get from shelf to the patient? You have to deal with a lot of insurance, prior authorization. What have you failed? Why this drug? Explain to some high school person on the other end, like why you're trying to approve this medication for the patient. So it takes a lot of effort and a lot of pharmacists, nurses, a village, so to speak, to get that patient, that medication, infusion nurses or pharmacists to get that. So it's a long process. And so to get the molecule from the mice to human beings, we're talking $1 billion in about 10 years.
Yeah, and I think the problem in this space that we're talking about, neuroimmunology, so I alluded to this earlier about drug development, is that to get a drug developed and to show efficacy in clinical trials, you need one of two things, ideally both. Number of patients and in time, basically. That's called patient years. So you need large number of patient years. And the problem with neuroimmunology is that we don't have like a biomarker of saying, well, we've changed a number on a lab test, right? So like diabetes drugs, that's a very easy thing to develop because one, diabetes is very common. Also, they have a biomarker, the hemoglobin A1C, right? So all you got to do in a clinical trial for a diabetes medicine is show over, 6 months even, reduction in the A1C level. That's it. And then also safety. And also it's easy to recruit patients. But with like MS, NMOSD, we're not talking about a lot of patients. I mean, there's only about 25,000 NMOSD patients in the U.S. I mean, diabetes company can enroll 25,000 patients in a single clinical trial like there's no tomorrow. But in these worlds, it's very hard. And also it's very hard to show, well, how do we safely test these things and not cause harm, right? Because the biomarker that we have is relapse rate, basically, right? And that's bad. We don't want to have relapses, even in a placebo group. So it's very complicated to develop these drugs, especially in neurology. One thing about the FDA approval process, I actually think is very important because it's highly vetted primarily on safety is really the underlying theme with the FDA, right? So, and then now there's this added component of how efficacious it is. But the efficacy of a drug is predicated on safety, right? If the drug doesn't work, that's not safe, right? It's not just about side effects. So the vetting process is very complicated. It takes about 9 months on average to get a drug through the approval process once the results are done. And then regulatory-wise, that's sort of the checkbox for the insurance companies, at least in this country.
And I think FDA approval can help with access to a medication, certainly because of that, like Dr. Conte was saying. But also, drug companies want their drug to work. I mean, that's the goal, right? That's what we all want, not just them. And so oftentimes the patient population that are enrolled in these trials is a very homogenous one, not necessarily, and I think there's been a lot of discussion about this over the years, and we're thinking about this more and trying to recruit more diverse patients, but often, at least the historical trials have not been very diverse. They have a limited age range, like let's say for NMO. I mean, if anybody in the audience is NMO antibody negative, there are some medications that are not FDA approved for you. And I think that, that's another piece, even though FDA approval can improve access, if you're not in that bucket of patients that were studied in the trial, it still might not improve access for everyone.
So a word about pipeline that you also asked. So a comment about that is that, there are some target therapies that may introduce a new mechanism of action. There are therapies going after, the immunoglobulins themselves, the neonatal Fc receptor inhibitors. There are therapies that are going more into cell-based therapy, like the CAR-T therapies that are going into, still an anti-B cell therapy, but instead of an antibody binding to the B cell or the plasma cells, it's actually a cell that go after another cell. The benefit of that will be that you can penetrate tissues. You can go into, lymph nodes and the brain. But a comment I want to make is we were, as a scientific community and patients as well, we were spoiled in the last 5 years that we got so many therapies approved so fast. And that's part of the reason is because we didn't have anything approved. So it was relatively simple to enroll patients in a clinical trial. Because unfortunately, patients were having issues. They were having relapses and they were progressing. Now that we have all the therapies approved, it might become more challenging to enroll patients because it's a good thing to have. Patients are stable for the most part. And in order to be enrolled, you have to have evidence of disease activity. It might be possible that patients that don't have access to medications may be candidate for clinical trials. But also, it might be a situation in which might be a slow process of approval of medication. So I want you to prepare you that if you have 5 new therapies in the next 5 years, don't be disappointed because the field today is different to what we were having 5 or 6 years ago when these trials were enrolling.
All right, please join me in giving a round of applause to these wonderful panelists. Thank you all so much. So, where's the photographer? We're going to take a quick group picture of the 6 of us, and then we're going to do the big group picture with everyone, and then it's lunchtime. So.